Hello, everybody. It's Ryan here, your friendly physician. Hope you and your family are well. God bless you. Thank you so much for joining me. Yep, it's another mind map in internal medicine, and we are talking today about supraventricular arrhythmias. Now, if you haven't yet subscribed to my channel, what are you waiting for? Okay, I know it's a bit small, but we're zooming in, we're zooming in, we're zooming in. Supraventricular arrhythmias, there's lots to talk about today, guys. With all our mind maps, we start at the 1 o'clock position and we progress in a clockwise fashion. So we're talking about general principles, then we're going to break into sinus tachycardia, atrial ectopics, junctional arrhythmias, paroxysmal atrial tachys, Wolff-Parkinson-White, WPW, everybody's favorite cup of tea, atrial flutter, atrial fibrillation, and then we're going to end up talking about sick sinus syndrome. God bless you. Let's get stuck in. Don't waste time now. Okay, general principles, guys. How do patients who have arrhythmias present? Say, doc, I have palpitations. Sometimes they may not necessarily say I have palpitations. They say they have an uh, just an awareness, an unusual awareness of their heartbeat. So whether it be tachycardia, whether it be bradycardia, right? And you got to get the patient to tap this out, the cadence of the beat. And often, if it's tachycardia, we're thinking it could be supraventricular in origin. And of course, with that, it's associated with lightheadedness and presyncopal feeding. Alrighty, sinus tachycardia, the scariest rhythm in the hospital. Sinus tachycardia, the scariest rhythm in the hospital. Normal heart rate is between 60 and 90. If it's above 90, you know there's some tachycardia action there. And why do we say it's the scariest rhythm in the hospital? Because there is always a reason for the sinus tachycardia. And if we are responsible physicians, we would stop at nothing to ensure that we have worked out why our patient has a sinus tachycardia. All right, having said that, what are associations? So it could be exercise. Maybe your patient's exercising. Anxiety, of course. Fever, yes. So pyrexia is definitely the thyrotoxicosis, and of course the baby breakdown thyrotoxicosis. The most common cause is Graves' disease. It could be toxic multinodular goiter. It could be a toxic adenoma. Have a look at my, approach to thyroid disease on that one. Shock, shock, shock. That's a shocking thing. It could be blood loss. It could be myocardial infarct. So hypovolemic shock, yes. Cardiogenic shock, yes. Septic shock, yes. And then congestive cardiac failure, of course, because of the increase in your sympathetic tone. Drugs like vasodilators, yes. I'm talking to you, nitrates and constrictive pericarditis. Thank you so much. How do you deal with this? Well, you can beta block the patient provided they are not in acute pulmonary edema, okay? And use appropriate measures as well. Alrighty, ectopics are very common and are associated with, blame it on the alcohol, caffeine, so all your energy drinks, you know those energy drinks that you're fond of drinking. Cigarettes, anxiety, and hyperthyroidism as well. Junctional arrhythmias, yeah, so these often may be wide complex, okay, and these are associated with myocardial infarction, the digoxin toxicity, myocarditis, and this was relatively common in this era of COVID that we just came out of, and surgery in the way of cardiac. Now, paroxysmal atrial tachycardia is associated with atrial ectopics, okay, with AV nodal reentry and with ectopic atrial focus, okay. And clinically, the heart rate is going very high at about 160 beats per minute, but exercise may abolish it. What are the ECG characteristics of paroxysmal atrial tachycardia? Well, you got a very, very rapid rate. You got an atrial response, which is in multiples. So either 1:1 or 2:1. And AV conduction is either aberrant or 1:1 response. How do you treat atrial tachy? Well, you can use, kinetic sinus massage. You can use drugs like flickenide. So look at your Vaughan Williamson classification of antiarrhythmics. You know that there's 4 different grades. So class 1, flickenide will do. Amiodarone will do. Uh, Diazopyramide, not that common, but can be used. Beta blocker, definitely. Digoxin, as we know, is negatively chronotropic and positively inotropic. Verapamil, which is a non-dihydropyridine calcium channel blocker, as well as adenosine. So a lot of different drugs to choose from. Or, of course, if a patient's especially hemodynamically unstable, we want to give electricity and cardiovert, synchronized cardiovert to your patient. Wolff-Parkinson-White, WPW is an accessory pathway down the bundle of Kint. And we know that we have that beautiful delta wave on the ECG. Clinically, these patients come in with it's paroxysmal. It comes and goes. It comes all of a sudden and goes all of a sudden. And palpitations is the name of the game. On ECG, you're going to see the very shortened PR interval with the delta wave, which represents the accessory pathway of conduction, and the QRS is going to be wide. Therapy, you can use propafenone, sotalol, amiodarone, flecainide, diazepam. Um, and you remember, you don't want to give this, you don't want to give these drugs in the presence of atrial fibrillation. You don't want to give concomitant verapamil and digoxin, okay, because of precipitous lowering of blood pressure. Atrial flutter is where you get your sawtooth baseline, and this one is associated with atrial fibrillation. Investigate with ECG with and the AV conduction varies. The rate is between 2 and 300 beats per minute, so very, very fast. Sawtooth baseline, like we said, therapy is as in atrial fibrillation. And of course, atrial fibrillation we know is the commonest arrhythmia in clinical practice. What is it associated with? Thyrotoxicosis. Thank you. As well as with heart disease. Any cause of a large left atrium is a nidus for atrial fibrillation. Alrighty. And to that end, we speak about cardiomyopathy. What are the commonest causes of cardiomyopathy? I'm glad you asked. Well, ischemia, right? Ischemic cardiomyopathy, people who had heart attack before, hypertensive cardiomyopathy, alcoholic cardiomyopathy, RVD associated cardiomyopathy. What about postpartum? Oh, yes. Myocarditis, atrial septal defect, ischemic, and that due to mitral and rheumatic heart disease. Clinically as well, these patients may have sudden onset dyspnea. They may have a clot in the way of an embolism, which can also embolize out and cause cerebral infarctions. Uh, and it could be a left atrial clot, which can embolize as well. How do we investigate, guys? ECG will show us an irregular RR interval, right? We'll have a normal QRS and we have fibrillary waves. And the main thing is you have absence of P waves, all right? And your echo obviously will show you if there's any cardiomyopathy, if there's a large left atrial pressure, left atrial size, if there's raised pulmonary pressures. You know the deals right there, guys. Drugs, as we know, well, we can use if your patient's hemodynamically stable, amiodarone, or you can use a non-dihydroprotein calcium channel blocker, verapamil, beta blocker, digoxin, and you've got to decide based on your clotting risk. So we talk about the CHA2DS2-VASc score and the Hasbled score, and you got to counsel the patient and start the patient in anticoagulation. And which anticoagulants you can use, guys? If you got structural heart disease, no questions about it. You got to use either warfarin or DOAC, right? But if you got a prosthetic heart valve, there's no role for DOACs because they haven't been proven efficacious based on clinical trials. What we do use is warfarin. Okay, you can't hear about the patient, and as we know, it's paroxysmal. Um, how do we prevent? There's the role for social or flecainide, propafenone. And remember, there's also something called the holiday heart syndrome. Patients who go on holiday, they have alcohol, and suddenly they have paroxysmal atrial fibrillation. Guys, sick sinus syndrome is the last thing we're talking about today. It's paroxysmal and can give rise to atrial fibrillation, supraventricular tachycardia, or even bradycardia. Clinically, the patient presents with palpitations, which may be linked with presyncopal and syncopal episodes. How you can investigate ECG? ECG, we're going to have an AV block or sinoatrial block, I beg your pardon, and the rate can be fast or slow. Drug sensitivity to beta blockers and digoxin. How do you treat the bradycardia with a pacemaker? Alrighty. So everybody, we covered a lot of information today. Just zooming out now from our mind map. Supraventricular arrhythmias is what we spoke about today. We started off with some general principles. We spoke about the scariest rhythm, sinus tachycardia. We went into atrial ectopics, junctional arrhythmias. And we had a few words on paroxysmal atrial tachy. Wolff Parkinson White, the bundle of Kent, everybody's favorite cup of tea. Atrial flutter, atrial fibrillation, the commonest arrhythmia in clinical practice. Sick sinus syndrome, that's what we're talking about. Okay, guys, let's have a look at some ECGs. Yeah, what is this, guys? There's 4 important findings alongside. Feel free to pause the video if you so feel. Right, so what can we see, guys? So there's no P waves, right? There's no P waves on this, but the rhythm is regular. So you've got the RR intervals, it's reproducible and regular from beat to beat, from beat to beat, from beat to beat. What is this? This is supraventricular tachycardia. The rate is being about 140. It's regular. So if you had the same situation where you can't see P waves, but the rhythm is irregular, that's when we say, all right, atrial fibrillation. But this is supraventricular tachycardia. And the 5 most important causes can be physiological, can be thyrotoxicosis, can be ischemic heart disease, can be Wolff Parkinson White, can be dish toxicity. And we spoke in brief about all of these etiologies in our mind map. How do we treat SVT? Guys, well, rest and reassure. All depends on my blood pressure. If my patient's hypotensive, I don't want to talk about drugs. I want to talk about electricity. I need to synchronize cardiovert my patient. But of course, if you got patients of normal tensive, you got a blood pressure to play with, you talk about carotid sinus massage. Never do bilateral carotid sinus massage. Always unilateral at a time. Or Valsalva. Or throw ice on the patient's face like we saw in the residence. But Conrad is crazy, right? That increases vagal tone. or adenosine 6, 12, 12, so in 6 milligram increments up to a total of 3 doses. If that's refractory, beta blocker or digoxin. Like we said, if hemodynamically unstable, don't talk to me about drugs. Synchronized cardioversion. Okay, my friends, we're talking about holiness without love today. Now, the Pharisees had all their doctrines intact, but they had no grace in the way they spoke to people. They spoke the truth without love, and they are like skeletons. How many of you are excited when you see a skeleton coming to us? You know, people felt like running away from those Pharisees because they didn't have grace. Compare this with Jesus. John chapter 1:14 said, and the word became flesh and dwelt among us, full of grace and truth. So in Jesus, we see the perfect balance between grace and truth. Jesus spoke the truth in love. Amen. And we are called to do likewise. Let us show people that we believe the word and we will not compromise on the word. But at the same time, we will show grace and love, that people are attracted to us and we can give them the message of salvation. Amen. God bless you. Have a lovely week, and I'll see you soon.